I think this is a very important seminar. So studying along something which is a bread and butter of it's considered bread and butter in psychiatry. Is an umbrella of neuroscience, and the conceptualization can be only learned when we are well versed with the historical evolution of any diagnostic entity or any disease entity. In this context, this is an important. Even we are doing it in a series form like schizophrenia, then OCD, bipolar, depression, and other psychiatric disorders, so that can help the residents in their exams also. With this, I think Dr. Abhijit can start.
A very good morning, everyone. Today I'll be talking about history of schizophrenia, and my moderator is Dr. Shobit sir. So, in this seminar, we'll be covering first of all about different psychiatrists who came into the play and helped in the evolution of the diagnosis of schizophrenia, and we'll end up with the current diagnostic concept that we are using today. So to start with, can anyone tell me what does the word schizophrenia means? Anyone, like, what is the actual meaning of the word schizophrenia? Ma'am is correct. The word schizophrenia means the splitting of the psychic functions. So it's not that the schizophrenia before it was actually conceptualized by different psychiatrists doesn't exist. They always existed between us. The only difference what name it was given or what it was attributed to before. Like if someone is suffering from schizophrenia before, people used to think that it is a curse by some god, or they used to think it's like insanity, or they used to give it some supernatural thing. It was late in 1880s that different psychiatrists they started seeing some symptoms which were common in people, and thus they started working on it and started to define the disease. So this is a timeline of the evolution of schizophrenia. So it started in 400 BC, and currently and it's a long process in which the evolution of the disease happened. So we'll start with the history. So initially in the 1880s, many different psychiatrists in their own country, they started seeing people which have their very common symptoms. So they started giving the disease a name in their own native language. Like Morel in France, he gave the term demens precox, whereas in Scotland, Clusson coined the term adolescent insanity, where in Germany, different catatonic syndrome was given. However, in 1880s, Kraepelin, he came into play. He had a very important role that he integrated all these different psychiatric, all these symptoms which were there, he integrated it, and thus he gave us a single identity which is known as dementia precox. So, can anyone tell who is he? He's a very famous psychiatrist. Can anyone? Yeah, ma'am. Correct. He is the guy who actually gave the term dementia precox. So in his textbook, he gave he what he saw that people were suffering from a disease which have a very common symptom. So he gave the term dementia precox in his textbook, and he divided the dementia precox into 9 sub-classification, and he also told that these changes are there due to these different some changes in the neuroanatomical pathology and etiology. So these are the different 9 sub classification of in schizophrenia, which earlier was known as dementia precox. So the 9 different classification which he gave us: dementia precox simplex, arbitrania, depressive dementia precox, in which depressive symptoms were there, circular dementia, inner suppression followed by gradual onset of auditory hallucinations, whereas agitated dementia precox is there, periodic dementia precox in which the recurrent symptoms occur. Then catatonia was there, paranoid dementia, and schizophagia. Schizophagia is a speech disorder. We see them as schizophrenia. Eventually, and what he said that this changes which are it can be attributed to 2 things. the cognitive deficit, and the executive functions. The cognitive deficit, what he said, that there's general decay of a mental efficiency, whereas in executive dysfunction, there's loss of mastery of what we control over the violation actions that we have. Then he's the next psychiatrist who came into play, and he had a very important role in this further classification of the disease. His name is Eugene Bleuler. So he proposed that he's the guy actually who gave the term schizophrenia. Um, what the major difference between this Emil Kraepelin and Eugene Bleuler was that what Emil Kraepelin said, that schizophrenia is a terminal state of illness, whereas Eugene Bleuler, he contradicted this statement and said that no, it's not a terminal state of illness. It can be treated. What he said, that it's not a single disease, but what it is, a group of disease. And he also gave a fundamental distinction between the basic symptoms and the accessory symptoms. The basic symptoms are also known as the obligatory symptoms, and the accessory symptoms are also known as the supplementary symptoms. So the basic, his description, the basic symptoms, we also call them the primary, or the accessory symptoms, we call them the secondary. He gave four primary symptoms, which have four A's, that is abnormal association, autistic behavior, abnormal affect, and ambivalence. What Eugene Miller said, that this harmonic coordination among thought, emotion, and behavior, that is the hallmark of the disease. And Wheeler, what the secondary symptom, he said that there was hallucinations, delusions, the social withdrawal, all the positive and the negative symptoms that we see. Further, different psychiatrists, they came into play. They reclassified the disease. They gave their own concept of the disease, and thus there was further classification of the disease happened. The further classification of the disease comprises of the schizoaffective disorder, the schizophreniform psychosis, process non-process paranoid schizophrenia, and the paranoid schizophrenia. In this, one more in between, one classification also came of Ernest Kurzweil classification, who further classified the disease based on the body type of the person. So what he said, that a person who is more patla dubla, we can say he has a more chances of developing any psychotic disorder than a patient who is more endomorphic male, he has a more chances of developing any mood disorder. So though it was not validated, and the proposal was not accepted, but too easy in order to remember that this concept, we can say that any patla dubla, so patla dubla will start with P, so P can be attributed to psychosis, and any mota admi, M, so M can be attributed to any mood disorder. So it's easy to remember in this way. Then there was this process and non-process schizophrenia. We don't talk about this. In process schizophrenia, it begins in early stage of life. It develops gradually and is more attributed to the endogenous factor than the environmental factors. Whereas non-process schizophrenia, this is schizophrenia in which environmental factors they play a primary role rather than the endogenous factors. And this one more dichotomy model is there. In this dichotomy model, the psychiatrists, they told about that a person suffering from any psychotic disorder, he can be divided into two groups. Either the patient is having affective psychosis or a non-affective psychosis. Affective psychosis, what we know today is schizophrenia, in which the prognosis was not good. Whereas the non-affective psychosis, what we know today as bipolar disorder, the prognosis was good. So thus this also it lays a foundation for explanation of different spectrum of schizophrenia also. So the next slide is about, he's a very important psychiatrist in the evolution of the schizophrenia, because his contribution is today also it is helpful in the diagnosis. So his name is Kurt Snyder. So in today also we talk about his first rank symptoms, what he gave. So these are the first ranked symptoms which he gave, which we today also which is helpful in the diagnosis of schizophrenia. So the first ranked symptoms, it consisted of 3 auditory phenomena, 3 thought phenomena, 3 made for phenomena, 1 delusion perception, and somatic passivity. So he in auditory phenomena, he told us about first first person, second person, and person auditory hallucinations. Where in thought phenomena, he told about thought withdrawal, thought insertion, and thought broadcasting. Whereas in made phenomena, he told about made feelings, made impulses, and made violation. Then he told about somatic passivity. Somatic means soma means body, passivity not under control. So he told that the person suffering from schizophrenia, he said that his body is not under his control. Someone is making him do something. Whereas a delusion perception, he told, whereas that we are giving a false identity to any normal perception. Then further, Leonard came into play. He gave his own classification of the disease. He said that he further classified the disease into systemic, unsystemic, and the cycloid process. So according to him, in unsystemic classification, the primary role of genetics was there. He told that the genetical factors play a primary role in the unsystemic schizophrenia, whereas in the systemic and so the cycloid schizophrenia, the primary role was not of genetics, but it was a secondary. The primary role was more of a endogenous factors, like any if the mother is suffering from a maternal obstetric complication, the baby can have some issue further in his life. So his classification of disease was grouped into three groups. So first was systemic schizophrenia, which was insidious in onset, auditory and somatic hallucinations were present, delusion was there, early blunting of lip, effect was there, continuous re-emitting course, and personality deterioration was there, which includes paraphrennias, herbiphrennias, and catatonias. The second group which he told about was unsystemic, in which the genetic played an important role, which was rapid in onset, relatively preserve, preserve effect was there, remitting course, mild personality deterioration was there. It consisted of effect-laden paraphrenias, cataphasia, and periodic catatonia. Whereas the third group was there, which was known as cycloid psychosis, which was sudden in onset, pervasive delusion, mood, multimodal hallucination, labile effect, polarity of manifestation, typically complete recovery from episode. So anxiety, happiness, psychosis, what we know today as a bipolar disorder, motility psychosis, and confusion psychosis. So schizophrenia spectrum. So if you talk about the spectrum, can anyone tell what does spectrum means? What is the actual meaning of spectrum? So spectrum is a multiple phenomenology which has similar etiological basis, or to simplify it, you can say that it is qualitatively different but related to a single pathogenic link. So what I told you about that dichotomic model, in which it was explained that a person might be suffering from a non-affective psychosis and affective psychosis. These two are the two ends of the disease, but there are many other forms which were later discovered, which says that there are different forms of disease were discovered, which were actually were between these two, affective and non-affective psychosis. So in order to explain them, the concept of schizophrenia spectrum came. So they were different, like the term schizotype became, which was introduced by Rado and Mill, which describes the personality changes in the patient, which has anhedonia, ambivalence, interpersonal aversiveness, body image distortion, and cognitive slippage. These are the different schizophrenia spectrum. It is typical schizophrenia, schizotypal is the paranoid personality disorder, schizoaffective disorder, other non-affective which schizophrenia form, and psychotic affective disorder. Now we talk about the positive and the negative schizophrenia. So when Kremlin gave the term dementia precox, he used to use the term the defect and the productive symptoms, which we know today as the negative and the positive symptoms. So when he gave the term, he used to use the term the defect and the productive symptom, which we call it negative and positive symptoms today. Then further, another psychiatrist, he further classified the schizophrenia into type 1 and type 2 uh, uh, classification. The type 1 classification, it consisted of the positive symptoms which we know today as hallucination, delusion, any catatonic behavior, speech disturbance. Whereas the type 2 negative schizophrenia, where we see any negative symptom like anhedonia, any affect blunting is there. Then there's another classification of the schizophrenia known as deficit and non-deficit schizophrenia. People with schizophrenia, in which they have the primary symptoms are negative symptoms, they are called the deficit schizophrenia. Where the people in which there is the primary symptoms are the positive symptoms, they are called the non-deficit schizophrenia. So one thing, this deficit and non-deficit schizophrenia, they differ in on the basis of their treatment, what is the course of the illness, what are the risk factors are present. So they differ on this basis. The classification was based on this basis. Though they do not differ at the age of onset, any length of illness. So for non-specific schizophrenia, at least 2 of the 6 negative symptoms should be present, which consist of restrictive effect, diminished emotional range, poverty of speech, curbing of interest, diminished sense of purpose, and diminished social drive. Where the other symptoms present are a combination of 2 or the more negative symptoms has been present for the preceding 12 months and always present during the clinical stability. Now we come to the modern diagnostic concept. So when the diagnostic concept was given in the DSM-2, so it has a very wide range, or we can say the diagnostic concept of the book was it had a very broad range of diagnosis. That's why the number of people who are diagnosed with schizophrenia was much higher than now. So the DSM-2, it adopted the theory of Bleuler. So then further changes were made in DSM-2 to DSM-3, which we'll talk about further, which actually narrowed down the diagnostic concept that and which was more reliable in nature, and thus it paved the way for a better diagnostic and a reliable concept of schizophrenia. So in the major contribution that was made that in 1972 by the Washington University Psychiatry Research Group in St. Louis, Missouri, that he introduced a classification system aiming at greater validity and reliability of the source diagnosis. So these criteria, what they called them as feature criteria, which were based on the clinical description of the with the disease criteria were based on the clinical description of the image, the laboratory study, the delimitation from other disorders, the follow-up studies, and the family studies. So, and what was the next major step that was taken in the development and the diagnosis of schizophrenia was the introduction of the research diagnostic criteria in 1978. So they actually what they did, they combined the effect of future criteria and the Snyder criteria was the first time symptom, and they combined all these two, and further they gave a proper diagnostic approach to the disease. So that approach was contributed into DSM-3. So only difference between the Pfizer and the RDS criteria that there was a reduction of the duration of active symptoms from 1 month in Pfizer criteria to the 2 months in research diagnostic criteria. So if we talk about the current diagnostic criteria, currently we are following we followed the ICD-11 or DSM-5. So in ICD-11, some changes have been made from the ICD-10, wherein in DSM we have been following from a long time. So the DSM-5 requires a minimum duration of 1 month, minimum duration of 6 months of illness, where at least we should have a 1 month of active symptoms, as opposed to only as suppose in ICD what we talk about is that only 1 month of active symptoms should be present, whereas in DSM we talk about the symptoms should be present 6 months with 1 month of active symptoms. So these are the changes which were made from ICD-10 to ICD-11 in the diagnosis of schizophrenia. So there in ICD-10 there were different subtypes were present, which were later removed in ICD-11. and thus there was more emphasis on the Snyder criteria in ICD-10, where there's de-emphasis on the Snyder criteria in ICD-11. And now what we talk about, that there is introduction of new courses specifiers like the first episode or the recurrent episode. These criteria were not present in the ICD-10. So if we talk about the DSM and the ICD-11 criteria, only we all know that in criteria one or two of the more following symptoms should be present. The active symptom should be present for at least 1 month with total duration, with the duration of illness with 6 months. These are my reference. And so the ICD-11 consists the symptom must persist for at least 1 month in order for diagnosis of schizophrenia. The core symptoms will be persistent delusion, persistent hallucination, thought disorder, experience of influence, passivity of control, and psychomotor disturbance. That how many? So, so the new criteria says that out of the 6 criteria, five, two should be present, sir. At least for 1 month. For the previous slide. Yes, sir. So you're saying these course specifiers are not given in ICD? No. So these are the new. This has been introduced new. So
it is given. Course specifiers हैं वो अलग हैं. 20.91 एक और yes. That is course specific. They are given. Complete remission, incomplete remission. 0.01. They have changed the specifiers, but was there. So I think with this we open the floor for questions, comments, clarifications, contributions.
मैम वो ग्रीक माइथोलॉजी यूज करते हैं. मैम ये कह रहे थे मैम that these are the curses by God, hypocritism. So initially they used to attribute it to any supernatural thing or any insanity, any devil is present. So इनका start यहीं से हुआ था. When later the different cycles. Yeah, next one.
The questions, clarification. 1 second.
So the concept of deficit and non-deficit schizophrenia, that the people who are suffering from deficit schizophrenia, the primary symptoms will be negative symptoms, and the secondary symptoms will be all the positive symptoms that we see. Whereas the patient suffering from non-deficit symptoms, their primary symptoms will be positive symptoms, and the secondary symptoms will be negative symptoms.
The primary negative symptom schizophrenia is deficit symptom. Syndrome इसलिए कि एटलीस्ट 12 महीने दैट इज अ रेलेवेंट थिंग. जो हम लोग तुरंत पेशेंट को देके कहते हैं नेगेटिव सिम्टम्स हैं, चलो एमिसल प्राइड, दैट इज नॉट राइट वे. हैव टू रूल आउट. जाओ नेक्स्ट स्लाइड. क्राइटेरिया में जाओ. यू रूल आउट एंजाइटी, ड्रग इफेक्ट्स, suspiciousness or other positive symptoms, cognitive decline and depression. यहाँ पे नहीं दिया environmental deprivation. So it has to be ruled out, and these are not present. Apart from all this, if all these 2 out of these 6 symptoms are present for 1 year, then this is an exact mainly negative symptoms, which is very difficult to find. So most of the negative symptoms which we find, they are actually secondary negative symptoms. So either environmental deprivation or a long-standing illness resulting in cognitive decline, or positive symptoms still being. So negative symptoms predominantly illness and illness to focus on the थोड़ा तो बहुत हो गई होगा. Cognitive decline है बहुत हो गया. So the Liddell's dimension he has mentioned. TJ Crow's type 1, type 2. Yes, Liddell वाला mention नहीं किए.
सर वो type 1, type 2 mostly मिल रहा है सर.
His opinion of spectrum he has mentioned. Any questions regarding this? Can I go to that last slide? The cognitive symptoms, what are the cognitive symptoms in ICD-11? They will include cognitive symptoms. Okay, so when I said included पीछे डिस्टर्बेंस में लिखा introduction of cognitive symptoms as symptoms of schizophrenia. But diagnostic में तो नहीं दिया. They have specified it.
No, sir, the only difference between ICD-10 and ICD-11, like there were 6 symptoms. So earlier, what they used to tell in ICD-10 that from A to D, so one should be present and
There. Question.
cognitive symptoms क्या है?
Presented it like their cognitive symptoms. Some before symptoms, possible symptoms.
Yes, yes.
मैं जो है ICD-11 में I think it out ICD में 5 symptoms नहीं. What symptoms? ये कहाँ से लिया तुमने, ये कौन सा हुआ है डॉक्यूमेंट ये बहुत वर्जन है ICD-11 के.
ये सर एक आर्टिकल जो मैं
Articles.
ये सब से
ब्राउज़र पे है
Yes.
ICD-11 ब्राउज़र है ये फाइल है ये नीचे की साइड है. So, any questions? Dr. Ayushi? Comments?
Secondly, to disturb attachment between a mother and a child, between a child and the parent of the opposite sex, and we called it as a closure of schizophrenic mother. That is in 1930s and 1970s. That was very popular.
Emotionally cold mother, schizophrenic mother. That's a cold.
In general, that is not just
Cycloid cycles also there are various subtypes. You mentioned this. So if someone who wants to actually understand schizophrenia, you have to not read the diagnostic systems of the patient, never get a grasp. All these historical documents, the way they have descriptively written the case vignettes, these are observational. They observed अच्छा इतना patient है, कुछ को episodic course हो रहा है, कुछ को नहीं हो रहा है, जो नहीं हो रहा है उसको हमने schizophrenia में डाल दिया, इसका episodic है उसको manic depressive illness में डाल दिया. That is what actually is got out. Anyone who actually wants to know and curious enough, not getting to see so many patients of schizophrenia, though it is not a thing here, you will see so many patients. You can actually go and read all this because then you will actually know what actually is it and you relate it to your patients. So these old documents, historical documents are very, very descriptive. Volumes of things are there. Vivekanand ji, comments? हम लोग उस पर एक सेमिनार करने वाले हैं, हो गया है अभी. अभी होगा, होना है ना. हाँ प्लीज डॉक्टर.
पहले तो मैंने सोचा था कि आप हिस्ट्री टेक्निक schizophrenia करोगे. So when I realized history of schizophrenia, I was like, yeah, it is
Sir, yes, I came very late. So we require this
topic because what we do in residency is just look up the diagnostic criteria and then think that this is schizophrenia. Schizophrenia is much more than you need to study textbook to understand what is the illness. Okay, because diagnostic categories change. So if you are just learning the diagnostic ICD-11 or only DSM-5, then you will miss the whole picture of what's schizophrenia. So each evolution, they also give an insight as to how we have reached, okay, why we have picked up some symptoms, why we have promoted some certain. The second thing, I think ICD-11 has three versions. Okay, there is a blue book, green book. So what is happening in ICD-11? That needs to be PCR is there, which is specifically for research. And then we have ICD-11 blue books, which we commonly use. That is not the only primary care workers can use, but also which is more simplified. But
It's not given key fitness and
that is not, it is not concrete. It is just a working diagnosis for management. Okay, and you will like it has more sensitivity but less specificity. PCR has more specificity, but then what will you do with the patients who are not diagnosed? Okay. Now, much of this diagnostic classification also is required for the purpose of insurance. DSM, that is why it makes diagnosis more easier. Since most of the categories I see DSM was easier to make because when you take a patient, you have to put a diagnosis code. Okay. And if it's not diagnosed in that code, then it will not get the insurance. So for that reason, they made it much easier for that, not for research purpose. Right? Again, for say research purpose, DSM-5 people like DSR, DCR is more specific. For example, they quantify things, make it much more specific. All right. So diagnostic guidelines, diagnostic criteria have their other, you can say, forces apart from the clinical findings and research only. For example, the Gale-Tourette syndrome. Okay, so earlier on in DSM, it was there that disability should be there, then only it will be counted as a disorder. Okay, but then there was this group who said that disability is not necessary, but we are still diagnosed with the illness. Okay, for or schizophrenia in remission, he still requires treatment. But disability is not required. That clause was taken out. Otherwise, earlier at the time of my residency, it was thought that if there is no disability, there is no disorder. Now it is different that even if a person is functioning, you can make a diagnosis. Okay, so there is this universal clause that without disability, you cannot have a psychiatric disorder. That is now not. Did you mention homosexuality as a disorder? That is also a very important landmark in. बस schizophrenia की बात कर रहे हैं. Sorry. I got lost in DSM-5.
Yeah, I think regarding this, it's very important that initially these observational findings were published by Kraepelin, Bloiler. Kraepelin was more of type 1, Bloiler was more of type 2 schizophrenia. Then dimensional model came. Then post-Kraepelin era came, which is also a question. Post-Kraepelinian era or definitions of schizophrenia. And then when it started to be included in DSM was this Wegener's criteria. To read Wegener's criteria is very interesting. Then it was adopted by RTC. And then subsequently DSM picked it up, I think third edition or second edition. And then it became operationalized. Then ICD 9 or 8, I think picked it up. This is how it operationalized. This becomes a very important concept to know, and this is only one part of what case study. It's much more depth of history of schizophrenia. A lot of other contributions are there. I appreciate Dr. Vijay because he has, you feel that from his presentation that he is trying to read a lot of it. I've sent him a lot of articles. He is little overwhelmed with the information. So he is trying to put it up in a meaningful way, which is I asked him not to put so many sentences in the slide. It's difficult to read history, specifically history of any disorder, specifically psychiatry. And also you have to be very particular with the terms, like this Eugene Bloiler. You have to actually go to the Google and you have to see the pronunciation. So Wikipedia will give you pronunciation of the word. So you pronounce them as they are. Okay, so that is more appropriate. Yes, yes. So yes, they're very ticked off. They are very particular, fussy about very schizophrenia. They get irritated. Either schizophrenia or schizophrenia. So like that, and it's a learning curve. I think, but you have done well. Thank you.
Just to add, like, you two people, where most of you are studying comprehensive. OTP has a, I think, better chapter written on schizophrenia on the point of view of understanding them. From the point of view of understanding them, I think if you study OTP, at least some things like schizophrenia, bipolar, you can read from multiple sources.
But this is a very important seminar. Actually, every slide is in question itself.
Yes.
Like schizotypy you mentioned. Schizotypy is asked in your exams.
Okay.
And so that is very Radu and Nigel gave that concept. Actually, schizophrenia personality, the deficits, and you have mentioned about schizophrenia spectrum. And one place you mentioned schizophrenia, schizoaffective. We would have given by Jacob Casson. So these are very important terms which we are not, which we are forgetting. Remember, your examiners will be old school examiners. They are trained 15 years, 20 years away from this time point. So they will be asking all this. They might not ask you ICD level at this point of time. They will be very and historical concepts. They will be very practical.
So what happens to the, say, I think we're ending here, but just like, what happens to those symptoms, Schneiderian symptoms?
So it was included in
Present day
DSM-3.
mental status in present day examination, if you get Schneiderian symptoms, what does that signify? Nothing, or does it signify something?
It signifies, like, so his contribution was, it had a great role in the changes that were made from DSM-2 to DSM-3, sir. So his criteria plus the fringe criteria, they all combined together. They gave a more comprehensive and a better explanation to the diagnosis of schizophrenia. So today also, if we talk about schizophrenia, we do talk about the first line symptoms.
So first rank पूछेंगे, second rank भी पूछेंगे, third rank भी पूछेंगे. So you can say कि these contribute to the diagnosis of, but they are not now the whole and soul synonym diagnostic criteria.
Like, say, ICD-10.
You can diagnose.
So like,
Yes. He himself.
But somehow other people.
Yes. Yes.
from ICD-10 to 11, the emphasis was more on standard criteria in ICD-10. But in ICD-11, they have de-emphasized this criteria.
Thank you.